So, hello everyone. I'm so happy to be back to you with the integrated rounds. And this time, me and Dr. Achin will discuss a very, very important question from your exam perspective. A very, very important question from your, perspective of your clinical life. And together we will be able to give you a lot of input on that topic. I'll request Dr. Achin to, maybe switch on his camera and get back on track. So once Dr. Achin is back on track, we should be able to, give you the required discussion, and I will, tell you the suspense behind the image that I'm trying to show you behind. So integration is a very, very important part of your new pattern of exams, especially central institutes and the NEET PG exam. And that is what we will try to build up every week with our two teacher perspective. So let me just see if Dr. Achin is around, and just let me get him back. So by the time Dr. Achin joins us back, I would like you to guess in the chat box. Okay. Are you able to hear me now? Everybody? Yes. Please tell me. Now, can you guess what is it that I'm going to discuss today? What is it that I'm going to discuss today? What is this particular pathology image showing us? It is showing us inflammatory cells. You can see this, a cuff of inflammatory cells surrounding maybe a parasite or maybe a disease, but there is an inflammatory rim surrounding it. So what I'm trying to tell you today is the basis of pathology, a lesion called as the ring enhancing lesion. And that is what we will discuss today. Why do we have a ring enhancing lesion? How to approach it? What would be the differential diagnosis? And this is what our goal will be. So Dr. Achin, over to you. I think Dr. Achin is having some technical difficulties. So whenever we use a term in radiology, a term called as ring enhancing lesion, my question to all of you is, what do you mean by enhancement? Anybody in the chat box, please let me know. What do you mean by the word enhancement? Enhancement means that if a lesion is taking up the dye, that means when I do a contrast CT or a contrast MRI, if I give IV contrast, if the area is taking up the dye, I will call it enhancing lesion. And when the enhancement is like a ring, when the enhancement is shaped like a ring, I will show it to you with an example. When the enhancement is shaped like a ring, let me show you example of a ring lesion. Please see this image. When the dye is taken up by the disease process like a ring, we call it ring enhancement lesion. Okay. Now, my question to you is, if we give IV contrast, if we give gadolinium in MRI or iodinated contrast in CT, the contrast material cannot be taken up by normal brain parenchyma. Can you tell me why? Because contrast material cannot cross the blood-brain barrier. Because of the blood-brain barrier, contrast material cannot go into the brain parenchyma. But can I ask you a question? What happens if you have an inflammatory tissue, if you have inflammation? If you have inflammation, blood-brain barrier is disrupted. Yes, Arnab and Indragini are able to pick up my concept. So if you have inflammation, the blood-brain barrier is disrupted. So what I'm trying to show it to you today is, if I see a ring enhancing lesion, what is happening pathologically is you have an inflammatory rim around an infective focus. Now, this infection could be a parasite, for example, neurocysticercosis, for example, Toxoplasma gondii, or could be this could be a cystic lesion, a parasitic lesion like neurocysticercosis or Toxoplasma, or the center could be a pus pocket. It could be pus. So if you have inflammatory capsule surrounding pus, that means you're looking at an abscess. Or if you have caseous necrosis in the center, surrounded by lymphocyte, plasma cell, giant Langerhans cell, granulomas, so giant cells. So that means you are looking at a granuloma like tuberculoma. So, but if you look back in pathology, what we are going to look at would be an infective focus surrounded by inflammation. So my question to all of you is, are you able to think without our, starting the discussion so far, that most of the time when we look at a ring enhancing lesion, we are looking at a infective process most of the time. However, there could be neoplasms which can look like a ring enhancing lesion, which we will talk about when we talk about the differential diagnosis to be considered. But first thing when I see is, if I see a nodule which is homogeneously taking up the dye, that means it is a solid tumor. It could be a neoplasm. Okay. If it is inhomogeneous with solid areas, necrotic area, could be a neoplasm. It is a smooth ring-like lesion. I am thinking maybe it's an infective process. Then I need to know, am I looking at an immunocompetent patient or an immunocompromised patient? And that helps me to further narrow the differential diagnosis down. And for that, I'll ask Dr. Achin if he can show us the scenario for today. Dr. Achin, if you're around now, let's start.
Okay, so here is what happens in the ward when we work, that when a patient comes with a ring enhancing lesion, that the physician tells please correlate pathologically, the pathologist says please correlate radiologically, and finally the verdict comes out as please correlate clinically. So let's see this one question that I hope you can solve for me. A 31-year-old right-handed male patient has got a history of HIV infection, and this particular patient develops headache and progressive right-sided weakness over 1 week duration, right? The MRI reveals a single ring enhancing lesion in the left basal ganglia as well as the internal capsule of the patient. The CD4 count that we have seen in the patient is very low, it's 10. And the toxoplasma gondii serology that we have done for this patient is found to be positive, right? So what is the most appropriate, what is the most appropriate thing that we'd like to do in the patient? Any guesses, any answers for this one?
So I think, most of the students who are there in the, chat and who are interacting with us right now, just like I mentioned that when we see a ring lesion, we are first thinking of an infective process. That is one of the things that we have in mind. And we have to look for, if you're looking at a immunocompetent patient or immunocompromised. So I think that is one of the reasons why Dr. Achin has created a question with HIV in the history.
So I'm waiting for their answers, if they can give me some answers for it. Just a second. I'll adjust my camera.
D or B.
Okay. Most of you are telling me D, it's fine. It's okay. So I'll take you back into this topic, which is known as toxoplasmosis. So I'll take some time. I'll just elaborate this topic, which we have not done much in the classroom also. So if you know this topic, toxoplasmosis, this one is considered to be the most common focal lesion in an HIV positive patient. So the most common focal lesion that we find in an HIV positive patient is toxoplasmosis. Now, is it an early complication? No, it is always considered to be a late complication of HIV, specifically when the CD4 count of the patient is found to be below 200. So there are 2 points that we need to call upon here, and remember that it's the most common, and the CD4 count has to be less than 200. Then only we think about it, right? Now the organism that is the responsible reason for it is toxoplasmosis gondii. Okay. Now, is it a ubiquitous organism? Is it present everywhere that we find around us? No, it is not at all a ubiquitous organism. Okay. So this is something which has to come into us. So what are the main sites or the areas that or the modes that we can get this infection into us? It is acquired via 1, undercooked meat, right? Cat feces, and contaminated water. So these are the three things that we find this infection into us. Okay. So this is something important that we find it in people who we see as immunocompromised individuals. And this particular organism finds its way into us from a normal diet, and it's not a ubiquitous organism that we come across with. Now, what are the clinical features if you find it? Quick. So we find a clinical symptom in them as headache, 1, fever, 2, and obviously a focal neurological deficit that it will try to create. And the third symptom that we'll find it over here is an altered sensorium. Okay. So few of them I remember are the most common presentation of this particular disorder, right? Now, we can also find in these patients chorea and hemibellismus. Now, can someone of you tell me in the class that if you find chorea and hemibellismus, then possibly where are you expecting the lesion to be in? Which part? Obviously, it has to be in the basal ganglia. So these toxoplasmous abscess can form in the basal ganglia that can often relate to chorea and hemibellismus as a movement disorder in them, right? Now, quickly I'll go to the investigation part. The first thing that we like to do in the patient is to get their serum IgG antibodies. They will come positive. Remember this. Now, if the titer is high for this particular infection, if the titer is high, there is almost 35 times higher risk for this infection to be there in the patient. Okay. Now, remember these antibodies can come out to be negative also in late and advanced stages of the disorder. In the late and advanced stages and newly acquired infection. So if the infection is newly acquired and it's a late advanced stage, then you can find these antibodies to come negative also. Okay. Now, should I do a lumbar puncture? Can you tell me about this thing? Should I do a lumbar puncture for them? Obviously, no. It's totally contraindicated lumbar puncture. Right? Now, for the reason because they present as a typical ring enhancing lesion. If you try to do a lumbar puncture for a ring enhancing lesion patient, possibly it will have a coning effect on the brainstem. So LP is simply contraindicated in these group of people. Okay. Now, what's the treatment? There's an induction therapy. There's an induction therapy that we offer in them, right? Which includes few drugs. One is pyrimethamine along with sulfadizine along with one more leucovorin, right? So these are the drugs that we offer for therapy in these patients, right? But if at all you don't find these drugs around, what is a Ramban therapy for them? Yes, something that you use very more often, trimethoprim and sulfamethoxazole. So trimethoprim, sulfamethoxazole combination is also found to be equally good, right? Now, how long should we give a kind of a induction therapy? Ideally, we should give it for 6 weeks time. Okay. And after this, we should decide if on a repeat CT scan, the lesion that you are finding is no longer enhancing. It's no longer enhancing. Okay, that means it's not flaring up any further. Then in that case, I like to offer my patient a maintenance therapy, right? of the same drug, trimethoprim, sulfamethoxazole, that we can give to the patient. How long should I give the maintenance therapy? Until the CD4 count is above 200. If it goes above 200, they're at a lesser risk of having this trouble. Now, a word that we should remember, in these patients, one thing is strictly contraindicated. What? Glucocorticoids. As far as possible, we should avoid using glucocorticoid in them, right? For a very clear reason, glucocorticoid, if you give them, it will often mask the symptoms of the disorder. Okay. Now, there's another thing that we should know about toxoplasmosis, that in our patient, if at all, I find there is no improvement that I see. No improvement for 2 weeks' time. That means I find my patient to be as bad and sick as earlier he was, and may even go worse sometimes. What is the next thing should I consider for? Now, I want your answers, because this is something a very interesting phenomena, HIV and all. You must have read it somewhere in microbiology, that if in a patient on treatment, you don't find any good of an improvement, then what else should you think about? Any answers? This will be something, I will give you a hint. This is the second most common mass lesion in HIV positive people. I'll give you the hint. This is the second most common mass lesion in HIV positive patients. Right? It's primary CNS lymphoma, not tuberculoma. It's primary CNS lymphoma that we find there. Now, what is this primary CNS lymphoma? It's a high grade, remember this, it's a high grade non-Hodgkin lymphoma, NHL. Okay, it's a B cell high grade non-Hodgkin lymphoma that you find there. And this can come even if the CD4 count of your patient is found to be below 500. So it can come in the early phase, right? Now the clinical features, if I see in these patients, would be a subacute kind of a focal neurological deficit that we find there, along with headache, and of course encephalopathy. Right? So the ideal treatment that we can offer these patients would be steroids. Steroids are given because they mimic toxoplasmosis sometimes. And basically the problem in them is that they've got a significant cerebral edema. And being a lymphoma, I need to offer them what? Whole body radiotherapy, one, along with methotrexate. My dear friends, answer for every question in India is not tuberculosis, okay? And I'm talking about HIV positive people. Chalo. So I believe we are wise in our answer now. A 31-year-old right-handed male, HIV positive, CD4 count, turn Toxoplasma gondii, serology positive. What is the best approach? Start with an anti-tox therapy without anti-edema. Sorry, I just anti-edema treatment like steroids. Don't use steroid in them. Okay. Starting a corticosteroid is not the correct answer. Going for a biopsy is too early. Radiotherapy and all will come later on. If in 2 weeks the patient doesn't respond to your treatment, because possibly then you think about primary CNS lymphoma. Okay. Right.
I think, Dr. Achin, I think I can show the images to them now.
Yes.
So what we will do is now that, you have understood what Dr. Achin has told you. I'm sure, we talked about the association of cats and toxoplasma. and I'll ask all of you in the chat box if you are aware of it. If a rodent is infected with Toxoplasma gondii, what happens? If a rodent is affected by Toxoplasma, what happens? Now, it is known by research, is very interesting, that rodents are naturally afraid of the cat. But once it is infected with, once the parasite, when the rodent is infected with Toxoplasma, it stops disliking the cats and is easily preyed upon. So there is some nature, laws playing a game with all these infections. So it's very interesting to notice that if you look at biopsy, this is how the Toxoplasma parasite would look like. And if you have toxoplasmosis in brain, when your CD4 count is less than 200, you would have slight thickening in the area where you have the parasite. And then you will have surrounding inflammatory cuff, which is going to cause, a chronic inflammatory infiltrate around it. This is what I want you to understand. Now, once we have the background, now it is very easy to see on the MRI. So I want all of you to understand what MRI are we looking at? We are looking at a contrast enhanced MRI in the case that Dr. Achin was talking about. And this is what is called as the ring enhancing lesion. But what happens is at the area where you have the parasite, you have some eccentric enhancement. So what happens in toxoplasmosis on MRI, actually what you see is called as, let me just write down, eccentric target appearance. So not only the lesion is ring enhancing, it has a eccentric target like appearance. And second thing I want you to appreciate, can you see this area around the toxoplasma lesion is very dark. That is all what is called as the vasogenic edema around it. And second thing, like Dr. Achin talked about, this is the area of the deep gray matter. It is not in the superficial part, it is more in the basal ganglia location. That was the part that we discussed today. So if I now give you an integrated picture, you saw the clinical picture, because ring enhancing lesion is an infection, but the spectrum of infection will vary in immunocompetent and immunocompromised patient. Further, even neoplasms are associated with HIV. So that is one of the reasons, if the patient does not respond to anti-toxoplasma therapy, we should consider a neoplasm of the brain associated with HIV. That was primary CNS lymphoma, and that is where we got the integrated picture. So remember, CNS lymphoma can happen in people without HIV also. Although it is strongly associated with HIV, if without HIV, that will be a solid tumor, but with HIV, it is more of a necrotic tumor. That is why it looks like a ring enhancing lesion. So ring enhancing lesion, toxoplasmosis is one DD that we have already learned, and primary CNS lymphoma is also a differential to be considered. I hope this gives you the picture that we need. So I'll ask Dr. Achin if he has any more clinical scenarios to consider on this topic. Let's see them.
Yes. Thank you, sir. So here comes the next question for you guys. A 50-year-old woman presents with lethargy, fever, hypotension, and she's been diagnosed with bacterial endocarditis for the same, and she's been given antibiotics for this. On day 2 of her admission, she develops right hemiparesis. That's a focal neurological deficit. The CT reveals a rim enhancing lesion in the left frontal lobe. She is having bacterial endocarditis. She's having a focal neurological deficit, and she came with fever, hypotension, and lethargy. Can you tell me one DD for this kind of deficit that she possibly has got at the moment? What is a possible running diagnosis, maybe working diagnosis in this case? What are you thinking about? We're thinking something about infective, and she is not immunocompromised as been mentioned in the question. Okay, so what else can you think about? In the left frontal region. Possibly an infection which we understand as what? The brain abscess. Okay. Now where are the brain abscess going to form? Obviously in the cortex, the brain. So which structure is more often involved in the brain abscess in this case? Okay. For this, I'll take you into the topic brain abscess now. See, like toxoplasmosis and maybe CNS lymphomas you have done in microbiology, especially toxo, they do it there. And pyramidal CNS lymphoma also somewhere in path we do. And similar is this topic brain abscess that you touch upon somewhere in ENT also. So what is a brain abscess? It is a kind of a focal suppurative lesion. So it's a kind of a focal separated lesion that we find there in the brain parenchyma. Okay. Now, most important is it capsulated or is it uncapsulated? Two things. So if at all you find it to be capsulated, then you think about the brain abscess. If you find it to be uncapsulated, you call this as inflammation of the brain due to infection, of course, is cerebritis. Is brain abscess a very common entity? No, it's very rare. The incidence is found to be 0.3 to 1.3 per 1 lakh of the population around us. So it doesn't seem to be a very common entity, right? Now, what are the common etiologies if I find for brain abscess? I'm talking about the organism this time. The most common organism responsible for it is the streptococcus. The streptococcus. Now, the second one in the list that we find with us are the anaerobes. After the anaerobes, we find with us Enterobacteriaceae. And after that, of course, we find our friend staph, staphylococcal. So that's the descending order in which the organisms are more commonly found. Okay. Now, what are the predisposing factors for it? Very important. What are the predisposing factors that we find for this? Regarding the predisposing factor, one, it could be kind of a direct spread that I might come across with. From where? Obviously from the ear, the nasal sinus and the dental area. So direct spread that I find can be from the ear, the otitis media. Second, the paranasal sinusitis. And third could be a dental infection. 1/3 people that I see around me having a brain abscess are due to CSO, right? And the common location of otitis media resulting in a brain abscess is temporal. That's the most common site. Second most common site they claim is cerebellar. All these have come in the exam, right? What is the most common site of brain abscess after CSOM, otitis media, right? When I talk about the paranasal, it's here, right? So the likely location will be frontal. So the ear comes near the temporal lobe and the paranasal sinus comes near the frontal lobe. Okay. Dental infection causing it is rare, 2%. Paranasal sinusitis causing this is still 10%. Okay. So that's the direct spread from a neighboring site that we can find this infection. Second, a distant spread. That is a hematogenous spread. When I'm thinking about the hematogenous spread, I have common entities like infective endocarditis, one. the lung abscess, head injury, or any kind of a neurosurgical procedure that we have done, even a UTI, or maybe a congenital heart disease. Now, the congenital heart disease that is commonly having this brain abscess problem later on is tough. We should not neglect it. Now, the hematogenous spread is usually seen in the MCA territory distribution. So, in the distribution of the MCA territory, we usually find it there. Now, in the MCA territory also, we find it more often in the posterior frontal and the parietal region. And this happens usually at the junction of gray and white matter. Okay, this all happens more often at the junction of gray and white matter. Do remember this. Hematogenous spread accounting for brain abscess, the incidence is around 25% of the cases. Most of the time, the hematogenous spread causing this trouble causes multiple brain abscess than a single brain abscess. This we should remember. If you have a patient with multiple brain abscess, think about a cause which is a hematogenous spread. That means it has come from somewhere else, right? Something basic pathology of the brain abscess we should know, that there are stages that this brain abscess will pass through. The first stage is a stage of cerebritis, where the whole thing is not encapsulated, right? So this could be an early cerebritis, or it could be a late cerebritis. The early cerebritis is from day 1 to day 3. The late cerebritis comes from day 4 to day 9, right? Now, what are the major pathological changes that we come across with in this patient? First, in the early cerebritis, we're going to have coagulative necrosis. In the late cerebritis, we are going to find the pus formation. Okay. Then after the stage of cerebritis, that we pass into a stage of capsule formation. So it becomes capsulated now, capsule formation. That has also been divided into two parts. Again, early and late. Right. Now this wala, the early comes from day 10 to day 13. And the late wala comes from day 14 onwards. The actual ring enhancement that you come across with a capsule formation comes in the early phase of this stage. While in the late phases, okay, the capsule will be there, but it will be a very typical thick capsule. Along with the thick capsule, it will have a lot of gliosis surrounding it. So it's like any pus infection that you find in your body. This time in the brain, it goes through two phases mainly, the cerebritis phase and a capsule formation, which have been divided on the number of days like this as early and late. So then for the pathogenesis part, when a patient with brain abscess comes to you, what are the typical clinical features, right? Here I find a typical triad over here, which can be seen as headache as a symptom, along with fever and a focal neurological deficit. So these three things are the must. More than 75% people with brain abscess are going to complain of headache. Fever again is there in more than 50%. And more than 60% of them will have a focal neurological deficit. That depends on the site. Again, plus minus something due to cortical irritation that you can find is seizure. But remember this, one thing is typically found missing in them. although it's a kind of infection going around, but in them, the meningismus, the neck rigidity or the signs of meningeal irritation is usually missing. This would come only when the pus actually moves into the meningeal layer. It's a focal infection in the brain, a pus-forming organism sitting there, unlikely to cause any inflammation of the meninges at the moment. So meningismus is typically found missing in there. Regarding the investigation, so we'll talk about it once in how does it look on a imaging thing. I'll just tell you about the treatment part. This is very important. Has been asked recently. The ideal drug that you consider for this patient is a third generation cephalosporin. Of course, my ceftriaxone, along with my friend to give me anaerobic cover, metronidazole. How long should we give it? We should ideally give it for a duration of 6 to 8 weeks time. Okay. Now the point comes in, should we give steroid to a patient of brain abscess or no? If you open your book, you'll find it. Yes, we give steroid. Yes, we give it. Don't worry. It won't let it spread and cause further reaction and all. But usually DEXA is given 10 mg 6 hourly to the patient. Now, this is very important. It has to be stopped and tapered fast. Very important. Don't have to give it too long. Basically, the funda of giving a steroid in them is to decrease what? Cerebral edema and the mass effect that we find. Okay, so steroids have to be given. Don't worry. Apart from this, the anti-epileptic drugs have to be used in them. And how long should I give it? We should give it for 3 months time at least, right? And then repeat the MRI of the patient. If the resolution is there, then we give it for another 3 months time. Okay. And then we taper and stop it. See, I'm talking about the word resolution because if you're at the late capsule stage, you'll have gliolysis there and that will become as an epileptogenic focus. That means everything has gone away. So at least 3 months you have to give, then repeat the MRI, although you might have done it earlier also, and then decide what you have to do. Okay. Maybe one decision apart from this can come from the EEG also. Just one more thing, that if at all your patient is a case of head injury or any kind of a neurosurgical procedure, and in them you have got a brain abscess, then the antibiotic choice has to be different. Ideally, in them, meropenem and vancomycin would work. Vancomycin would work, right? And most of the time for follow-up, we always advise for an MRI CT monthly also sometimes, okay? So that's all about the brain abscess as a case that we have. Over to you, sir.
Thank you, Dr. Achin. I think Dr. Achin has very beautifully described the entire case. And I just wanted to mention to the students who are listening to us that last year in the exam also we got a question where we had a ring enhancing lesion in a patient with ear discharged, and they had shown an abscess in the temporal lobe, just like Dr. Achin has beautifully described, that we have to look for a cause. Like for example, in the question that Dr. Achin had discussed, the case was of infective endocarditis. So he had a focus in the heart, infective focus, and from where the infection was spreading. Or it could be a contiguous focus.
Yes, sir. This one, sir.
Yeah. Or it could be a contiguous focus from either from sinusitis or from CSOM, like we discussed right now. And we discussed even in congenital heart disease, especially tetralogy of Fallot, you can have it. Now the question remains is, number one is location. Now, I want you all to understand there is something very important for all of you to understand. Any process which is hematogenous, any infective or metastatic process, like suppose tubercular lesion goes to the brain via blood, abscess via blood, or metastatic, has a tendency to lodge at the gray-white matter junction. Hematogenous process lodges at the gray-white matter junction. It is probably to do with the sudden difference in caliber of vessels that happens in gray and white matter, because there is a sudden change in the caliber at gray matter and white matter. So the metastatic lesion tends to lodge at this site. It's a border zone between two differently vascularized tissue in the brain. Now, how would it look like? I thought I'll show you example. The first is a T2 weighted image where you can see a fluid filled area which has a capsule around, and then you have edema all around. When I give the contrast, I can see ring enhancement. The center is not taking up the dye because it is pus. But my question to all of you is, how will you confirm? How will you confirm? So to confirm, I need to do another MRI technique sequence called as diffusion weighted MRI. I need to do a sequence called as diffusion weighted MRI. Diffusion weighted MRI is sensitive to Brownian motion. So if you have any abscess will have pus, and the pus will not be able to have any particle movement. So abscess appears bright on DWI. Abscess appears bright on diffusion weighted MRI. If hematogenous, the most likely location would be gray-white matter junction. So that is true not only for abscess, it is also true for metastatic lesions and tuberculomas also. And another point that I thought we should make here is that if you are looking at an abscess, we should know the stages of evolution. In the cerebritis stage, you will not see the ring enhancing lesion. Early cerebritis will only be seen like an area of edema with no enhancement. Then you have, gyriform enhancement. Then in the abscess formation stage that Dr. Achin was talking about, you will see the ring enhancing lesion, which is because of the capsule formation. So I think we have an idea on how to approach the question. Location, contiguous, any site, cause of the abscess will be there, that why it is forming. Maybe the patient has CSOM or sinusitis, something will be written in the question. And the clinching diagnostic feature on MRI will be ring enhancing lesion, which is bright on diffusion weighted MRI. I hope this gives you the picture that you require. I'll request Dr. Achin to show us the next clinical scenario.
Yes, sir. Thank you, sir. So here comes the next question. I believe the previous question should be clear. It's a case of brain abscess, and where are we going to see it? If it is from the hematogenous spread, it will be at the junction of the gray and white matter. Why I call this as a hematogenous spread? Because the patient has got bacterial endocarditis in the background. Next question is another question, a very maybe an easy question for you guys. A 45-year-old male has moved from Delhi. He suffers a focal seizure followed by the secondary generalization. He denies any symptom of active infection, has not recently suffered with any trauma. The MRI shows a typical lesion like this. A ring enhancing lesion with a significant cerebral edema around it. That's why possibly the patient started with a focal seizure, and then the seizures went everywhere because of the cerebral edema. Now, what should be the next step in managing this patient? Firstly, what you should think about in such a case? We should think about our friend, endemic friend, especially in North India, even all across the country now we find it, neurocysticercosis. Okay. Now, NCC caused by this organism that we all know as Taenia solium. Now, to complete life cycle of my dose Taenia solium, we find there are two hosts available with us. One, which we know is the definitive host, and the second host that we know is the intermediate host. Where is the intermediate host sitting? Who is the intermediate host? Pig is the intermediate host. It has got I, it's intermediate. And we are the second people in the list, the human being. Okay. Now, what is special in Taenia solium that it escapes out the host immune reaction? That means it is lodged into my brain somewhere, and it is happy to sit there for such a long time. Yes, this is something that we find the tinea sodium has got a substance which is known as tinea statin. Tinea statin secreted by this organism helps it to escape out the host immune reaction. That means this is a parasite which is going to live in us for a very long time, right? Now, the clinical features of NCC, if you know, number one, anytime is seizure disorder. The most common presentation of NCC anytime that we come across is with seizure disorder. The second could be headache. Third could be an obstructive hydrocephalus. Right. The fourth, the racemose form, that means it sits in the brain for a longer time, can even cause chronic meningitis. So these are the common symptoms of a patient of NCC who is going to come to you. Now, remember this, symptoms are something which can appear in it even 1 to 5 years after the infection. So when the infection has happened in our patient, 1 to 5 years after the infection, we can find the symptom there in the patient and can come even several years later on, right? So what are the investigations that I'd like to order apart from the MRI and all that we'll do? There's a special test that is a blood assay known as enzyme link immuno electro transfer blot, such a big name. So this is what is known as EITB-assay. So this is one blood test that we often advise nowadays. Basically, it's one which can catch the organism very well. Okay, so it's a kind of an antigen testing which can catch this organism very well. Now, the specificity of this test is found to be 100%, and the sensitivity has been found to around 98%. So this is one test that we can advise to the patient. Second, as far as possible, avoid doing a lumbar puncture for diagnosis. You are not going to get anything great over there, right? So, like, over to sir now. I think so. He will tell us about the radiological features about NCC that we find in the brain.
So thank you, Dr. Achin. So what I will want to show to you is a pathology image first, and I want you to see these parasites lodged in the brain. Okay. So you can see them. They have an intact membrane, and many of them have a eccentric scolex inside. So this is how cysticercosis would look like when you are looking at a gross specimen of the brain. My question to all of you is this. My question is this. If you have NCC, okay, my question is, do you see ring enhancement or not in this particular stage, or what stage is this? What stage are we looking at? So when you see this, you are looking at a cyst with scolex kind of appearance. This is called as the vesicular stage. Vesicular stage is the viable stage. And when the cysticercosis is viable, it does not have any inflammatory response surrounding it. So it is a non-enhancing lesion. I will show it to you on the MRI. Now correlate. Now please correlate the two images that I showed you. One was gross anatomy, one other is a T1 weighted MRI. You can see the appearance, cyst with scolex, cyst with scolex, cyst with scolex. Are you able to see that, Peter? Are you able to understand? Cyst with scolex appearance seen in vesicular stage of NCC. Vesicular stage of NCC. So I will now request Dr. Achin to maybe show us the question again, and then we can talk again about it, because the question is, In the vesicular stage, it is unlikely that the patient would have the edema or the inflammatory response. So when we look at the full question again, and I'll ask now Dr. Achin if he can tell us now. So Achin, now this patient has a seizure followed by generalization. So do you think this is the patient is in the vesicular stage or in the degenerating stage? Now, if we now look at the gross anatomy, we will see that in the vesicular stage, there is intact membrane around it. So the inflammations around it is almost negligible. When the parasite begins to degenerate, then only you start seeing an inflammatory rim around it. I want all of you to see the difference. In the vesicular stage, you have cyst with scolex appearance. So you do not have edema or ring enhancement. When the parasite begins to degenerate, we call it colloidal stage because the liquid inside becomes more gelatinous. You have ring-like inflammation around it and you have edema around it. Dr. Achin, what do you say?
Yes, sir, you are right, sir, because this is something which is important for a physician also while treating the patient, that if a patient has come to me with focus seizure and secondary generalization, apart from the anti-epileptic that I give to my patient, I should always try to give an anti-edema measure also. And most of the patients of NCC get symptomatic in the colloidal stage when the edema starts rising up much more. So that's again an important thing that the radiologist has to give me an information that are we seeing this patient in a vesicular or a colloidal stage. I'd like to share my screen again. So here's my question again, and that's the image. So one thing is very clear, there's a significant edema and a ring enhancing lesion that we have seen. So this is something beyond doubt that we have to give a patient a drug, one, to kill the worm. Apart from this, the anti-edema measure also. Right, sir?
So let me ask a question again to children. If you see a ring enhancing lesion, then it is colloidal stage because you have edema, maximum edema surrounding it. That is when the patient is symptomatic. And if you see a cyst with scolex appearance with no ring enhancement, no edema, that is the vesicular stage. Then what will happen is when the parasite is degenerating, the cysts start to retract. It starts to become smaller and the capsule, inflammatory capsule becomes thickened. So the inflammatory enhancing ring becomes thickened, edema reduces, and the cyst becomes smaller. That is called as the granular stage. And then the parasite dies. And when the parasite dies, what will you see on the imaging? Anybody? When the parasite dies, you will see, anybody? You will see calcification. So this is what is called as the dead stage or the nodular calcified stage. Nodular calcified stage. Are you clear? So stages are viable stage, which is the vesicular stage. Appearance, cyst with scolex, usually no enhancement, very minimal to nil edema. Then colloidal stage, maximum edema, symptomatic, ring enhancing. Then granular stage, cyst becomes smaller, but still there is enhancement, still there is edema, but the cyst becomes smaller, edema reduces. Then ultimately it becomes a nodule of calcium, which is the dead stage. So this is how the parasite, the stages of NCC are. Now, one of the questions that a lot of people will ask you is, sir, how do we differentiate between a NCC and a tubercular lesion? We will discuss it with TB, but remember, cyst with scolex appearance is typical of NCC. This is definitely NCC. And secondly, if I see multiple stages in one image, that means if I see one nodule which is non-enhancing, one calcified, one ring enhancing, this is typical of NCC, because when you give the treatment, some parasites will be alive, some will start dying, some will be dead. So if you see multiple stages of the parasite in the same image, that is likely to be NCC, that is unlikely to be tubercular. Presence of other features which favor tuberculosis, I will tell you with the next question. I think Dr. Achin, do you have a question on tuberculomas?
Yes, sir, I have got. I'll just wind up this NCC story because we have got a nice diagnostic criteria also for human cysticercosis. When we are about to diagnose this patient of NCC, what are the things that we will keep in mind that it is a case of NCC, nothing but NCC? The absolute criteria. which includes the radiological demonstration of the cystic lesion containing the characteristic scolex. This is a very, very important thing. Second, you can find the parasite in the eye on the fundoscopy. I've seen one patient who came with this problem. And maybe you can go in for the actual demonstration of the organism by the biopsy of the thing. Apart from this, the major criteria again happens to be the test that I've told you, the ETIP test, the antigen test, which can be included in the major criteria, neurological again, and something which we often find in our clinical sense that if the lesion is resolving after giving an anti-parasitic agent, then we are very clear that it's a case of NCC. So the definitive diagnosis includes at least one absolute criteria, okay, or two major criteria, a minor criteria, or maybe one epidemiological criteria. In the minor criteria, maybe we can think that the lesion in MRI is suggestive of NCC. The clinical manifestations are of NCC. Maybe in the CSF, you've done a LISA and a cigar-shaped soft tissue calcification if it is a case of muscular NCC. But out of them, the major and the absolute are the things that always help us to guide through. Like Sir said that a patient of NCC has come in 3 stages, right? Let me remind this back because this is something commonly asked in the exam. Stages. The first stage is the vesicular stage, the viable stage. The second stage is the colloidal stage. Third stage is the stage in which the granuloma will appear. And the fourth is a dead stage, that is a calcified stage. Okay. Now, if I locate on the MRI, the cerebral edema that I find, this has been an age-old question. It will be maximum in the vesicular, colloidal, can be seen in the vesicular. Granulomatous it will reduce, and calcified it is often found to be missing. Let us connect it clinically. Seizure disorder, if I find it, it will be more often in a colloidal stage, can happen in a vesicular, and a calcified, and this one is always a plus minus. Now the anti-parasitic treatment that you like to give. Yes, I hope you know albendazole. Which stage should I give it? This I keep on asking every student in every class. Obviously in a vesicular stage I'll give. Colloidal also give. But as far as a granulomatous and a calcified stage, there's no point giving it because the worm is already dying and already dead in the calcified stage. The albendazole that you give to the patient is given at a dose of 15 mg per kg per day. The standard minimum duration is taken as 8 till 28 days, right? And always remember the first thing that you give before all this is what? Steroids. Very, very important thing. Because albendazole will enter the ring enhancing lesion, increase cerebral edema, and you'll be in a big, big trouble. So steroids have to be started prior to the albendazole therapy. Don't forget, give an anti-epileptic drug also to the patient to control seizure. Okay. So let me get back into a question. So this was that lesion that we are thinking about. One thing, why are we not thinking in this case a brain abscess? Because there is no symptom of any active infection or trauma. Brain abscess doesn't happen to be occurred like this, right? Secondly, it's coming from the endemic zone Delhi of neurocystic psychosis. As they say, you can take a man out of Delhi, but not Delhi out of a man, right? So you have to give an anti-epileptic, steroid, followed by albendazole. That's the right treatment for the patient. Okay. I hope this topic should be very clear because this is the maybe one topic which keeps on coming at least once in a year in ionized CT pattern. Okay. Next question is 23-year-old female is a known case of TBM on ATT for the last 1 month time. She presents with right hemiparesis and recurrent seizure. Which of the following investigation is not to be done in her urgently? Which of the following investigation is indicated in her urgently except? Okay, so we know that tubercular organism can live in me. Yes, and it can cause TBM, and one more problem, it can lead on to what? Tuberculoma. See, this is something which is considered to be the most common cause of focal mass lesion in developing countries. So in the developing countries, if I look around, the focal mass lesion that I come across is more often a tuberculoma, right? Clinically, when a patient of tuberculoma comes to me, what are the symptoms? One, they come to me with seizure, focal neurological deficit, and all the signs and symptoms of raised ICP like headache, projectile vomiting, papilledema, and all that. Okay. Investigation, sir will tell you about the MRI. But should I go for an LP in a patient of TBM? Again, as far as possible, avoid it because it will just cause a downward displacement of the brain like transtentorial herniation, coning, and death, right? So you need to be very careful about it. So LP, as far as possible, should be avoided. In a patient of tuberculoma, the treatment remains the same like TBM. We have already done an integrated session, I think, so a few months back on this. In them, the ATT has to be given for at least 12 to 18 months time. There's no point of 6 to 9 months. You have to give it for a longer time in patients of TBM or even tuberculoma. And secondly, of course, yes, steroids have to be given to the patient for at least 2 months time. And I'll tell you the story. I followed up a patient of tuberculoma in my OPD once, and I started him on ATT and got his MRI repeated after 3 months. And to my surprise, the lesion started increasing in size. This is a very common habit. See, it's not tuberculoma. It's actually a tubercular abscess, which has got into the brain with a good amount of caseous necrosis there inside. And now this abscess will encapsulate to become a tuberculoma, and everything slowly, gradually inside will dry out. But when the encapsulation happens, we find that sometimes the size might increase. So we should not be worried about the size of tuberculoma. That, oh my God, it has increased in size. That means I'm missing something apart from tuberculoma. No, it might increase in size. See, steroids do one thing good. The local tissue reaction that can happen, which might be a possible reason for increase in size, can be prevented by giving steroids also. That's why we give steroids to every patient of TBM, ideally. Okay. Okay. So let's get back into the question and solve it fast. What are the investigation I like to do and what are the investigation I not like to do? If it is a case of TBM has been on ATT for the last 1 month, and patient has come to me with recurrent seizure and maybe altered sensorium also, then I can think about what? ATT-induced hepatitis. One thing I always think about, which can happen. Okay. Second, maybe I can think about in the patient hyponatremia due to raised ICT. Raised ICT releases a higher amount of BNP that causes natriuresis and cerebral salt wasting hyponatremia. Third, I think about, of course, a tuberculoma, like in this case. She has come with a focal neurological deficit and seizure. Can be an infarct also, which can happen. And the fifth thing that we can think about is a hydrocephalus. So this has been an old question in one of the AIIMS exam again. And TBM overall as a topic is very important. As an Indian, you should know about, because TB, someone told me, is our national disease. I agree with him, because most common meningitis in India at the moment is always a TBM. Anyway, let's find tuberculoma and infarct by doing an MRI, hydrocephalus by doing a CT, hyponatremia by checking the patient's serum electrolyte, and liver function test for hepatitis. So one thing I will not do urgently in the patient will be a CSF analysis at the moment, because if I miss tuberculoma and I go and do it, I might go and do some coning and death might happen in the patient. Okay. So over to you, sir.
He has beautifully described I think all the ring lesions, and he's already covered almost everything. So let me just revise for you. This is what we meant when I said scolex, and this is what Dr. Achin meant when he said, so this is neurocysticercosis, we are clear. We have to differentiate from tuberculosis. Now, TB, what is happening is, TB, the center of the disease is not cystic. It is very important. In TB, the center of the disease is caseous necrosis surrounded by a granuloma formation. So you have caseous necrosis surrounded by all that granuloma cells, plasma cells, Langerhans cell, giant cells. So you have all those cells making a granuloma surrounding the area like this. So this is tuberculoma. So because the center is not cystic, it is not water, it is necrotic. So it will be dark on a T2 weighted image. Always remember, NCC, the center is cystic, it is hyper intense on a T2 weighted image. Tubercular centers are hypo intense on a T2 weighted image. I want you to see this now. Now you see these multiple lesions which are dark on T2 weighted image. How do I know this is T2 weighted image? CSF is white. And you can see there is extensive edema. So let's see point number 1. Why this is not neurocysticercosis. Neurocysticercosis will have a bright center on T2 weighted image because it is cystic. Tubercular lesions do not have water in the center. They are necrotic. So they are darker on a T2 weighted image. Edema is more around the tuberculomas as compared to NCC. You can see extensive edema. Okay, and when we give the IV contrast, when we do the post-gadolinium T1 weighted image, you can see multiple ring lesions joining together, just like a bunch of grapes. So NCC, the ring enhancing lesions were discrete. Can you tell me in the chat box, in tuberculomas, the ring enhancing lesions will be conglomerate. They will be like a bunch of grapes together. They will be conglomerate. So if you see conglomerate ring lesions, tuberculoma. Okay. T2 hypo-intense core, tuberculoma. More vasogenic edema, tuberculoma. And we will also see that because tubercular focus can rupture into the meningeal system, it can rupture into the subarachnoid space. So you can also see there is associated meningeal enhancement. So if with a ring enhancing lesion, you also see meningitis, meningeal inflammation on the MR, we think of tubercular lesions. And we also know that the necrosis in tuberculoma is rich in lipid. So if we do a MR spectroscopy, what will we see? Anybody? If we do a MR spectroscopy, what will we find? Anybody? Let me know in the chat box that you are aware of this. You will find a lipid peak. You will find a lipid peak. Lipid peak on MR spectroscopy is found in tuberculomas or toxoplasma, but not in neurocysticercosis. Because neurocysticercosis has a parasitic center, which is a fluid of a cystic parasite, while tuberculomas have a necrotic center, which is rich in lipid. So you will see the lipid peak. I am sure, Indragini, Sudhiv, Arnab, all of you are able to answer. Let me show you one more example here. Now look at this image, ring enhancing lesions. Any one of you in the chat box, tell me, tubercular ke cysticercosis, batao? Conglomerate, can you see them? Should I zoom it again? Multiple ring lesions stuck together like matted lymph nodes. Conglomerate ring enhancing lesions. Think of tuberculomas. Are you clear, Peta? Are you able to answer? Yes. So I'll now request Dr. Achin to maybe come online, and so that we can take a quick picture for Instagram together. And any final, words from Dr. Achin, if he can tell us something interesting right now.
See, I always tell it to the student that a physician is a doctor who knows everything and does nothing. He just orders for an investigation. Surgeon is a person who knows who knows nothing and does everything. He operates on everyone. And finally, we have a pathologist and a radiologist who knows everything and does everything. Maybe radiologist does early and pathologist does it late, right? So this is a kind of an integrated thing. It should not be any colaveri that this ring enhancing lesion or this or that. But finally, we should understand a patient is a case of a ring enhancing lesion has come to me. That particular patient is immunocompromised and his toxoplasma antibodies are positive. One thing is clear, toxoplasmosis. He's immunocompetent, keeping fever with some infection in the body, somewhere else or nearby the brain. Then we think about the brain abscess, right? And if at all it's a case of TB in the background, it has to be a case of tuberculoma, or maybe if nothing like this, we should think about neurocysticercosis. As per the data given by the Indian Society, it's very clear that around in the young people, NCC is fairly common. Need not, it should be something that we should always try to pick it around. And most important, visualizing the Scolex is very important here.
And as far as I'm concerned, only thing that I want all of you to remember is that many of you are going to be appearing for the INI-CET exam in the upcoming week or so. So my question to you is that every time you are approaching exam, you will have a lot of noise all around and inside of you. चारों तरफ भी होगा कि यार नहीं हो पाएगा, सेंट्रल इंस्टीट्यूट नहीं कर पाएंगे, यार बाकी लोग तो कर पाते हैं, मैं नहीं कर. You have so much noise all around, and there will be so much noise inside you also. Am I good enough? Will I be able to do it or not? Only thing that I have seen in life is that people who do well in life are able to somehow shut off the noise. कुछ भी करके इसको बंद करके फोकस करना पड़ेगा. मुझे ऐसा लगता है कि if I do something with my full concentration without getting distracted, it is as good as meditation. It is as good as prayer, which can help me, relax. Like for us teachers, I will tell you on behalf of Dr. Achin also and all our other teachers also that what we have learned over the years is when even we have our own struggles and noise all around, noise inside, noise. But when we are teaching, we enter into a zone where we are truly into what we are doing. And then that becomes silence, and then we come back rejuvenated. And that is what I want you to enter right now. When you are in the upcoming, a big exam is coming up. If you have too much noise around it, it is, disturbing you. It is disturbing your concentration. Get into that zone of silence. सोचो किस तरह से मैं इसमें और deep जा सकता हूँ. As far as resources are concerned, in the final week before INI-CET exam, I would suggest revise your DVT 2022, revise previous 3 years papers of INI-CET or AIIMS PGI JIPMER papers, which are given in your PPE kit in the eMedicoz app, and some topics from the AIIMS capsule, including the COVID capsule that is there in your AIIMS capsule. I think if you can do a mix and match of these 3 things. If you have more time, I would also suggest looking at a course on eMedicoz app called as the emergency room, where we have covered all the commonly asked emergencies in one session. So I think all this put together will give you the 360 perspective that you need in your exam. So what will help you do well in the exam would be mindset and ability to, ability to shut off noise, focus at the task of action, get into the journey mindset that, okay, I'm enjoying myself. I am not bothered about the outcome. Think more about the journey, less about the destination. बार-बार सोचेंगे कि मुझे enjoy करना है पेपर को, मुझे सबसे अच्छा एग्जाम देना है, जीते या हारे बाद में सोचेंगे. But focus on the journey right now. Don't forget to look at the previous questions. Don't forget to revise the DVT. Don't forget to look at things like AIIMS capsule, emergency room, which are very high yield revision. AIIMS people, they love concepts, they love integration, they love emergencies. So I think this should give you the perspective that you require. Me, Dr. Achin, all the faculty, we wish you all the best for the students who are appearing in the upcoming exam, and all others keep, studying. And this is one course, this integrated rounds. I am telling you, this is one course that you will be subscribed for life. I'm telling you, you will not like to unsubscribe this course ever, because this will keep teaching you something even when you are practicing. Dr. Achin, one final message from your side.
Yes, sir. Eid Mubarak to all of you.
Yes, definitely.
May the Almighty Allah bless us, and we all succeed in our dreams all the time, right? And stay safe, stay healthy, and stay healthy mentally also. That's equally important at this moment, because it's more a mental health that is important for you than a physical at the moment. So stay at peace, stay calm, and whatever you have done, it's good for you. It's not bad for you. Nothing you have done bad till now, you'll do good in life also.
जो होगा अच्छा अभी तक हुआ है तो आगे भी अच्छा ही होगा. On this note, we wish you all the best. Good night.